Okay, thanks for having me. It's great to speak to this audience, especially after hearing the last two talks, because it makes my talk a lot easier. They've done all the background for me. I am an educator, I'm a clinician, and I think I'm a little bit unique in Canada in that I mostly taught myself liver disease, and now I'm a hepatologist. But by having had to do that, I actually learned about alpha-1 in the 1990s when nobody else knew about alpha-1. I asked certain questions like, does heterozygous PIMZ cause liver disease? So I biopsied a ton of people, and we never found liver disease. So I'll be interested to hear what you do going forward. A few comments. So as my role as an educator, I also know to set my expectations low for what doctors know. So it's great to see you guys have this amazing organization where your patients are actually helping each other. Nowhere else in liver disease do we have a comparable organization. But for guidelines, whenever we put out, we fight to have guidelines saying, yes, my disease is important, but realistically speaking, whenever you have a guideline, only 20% of doctors will ever follow that guideline. So set your expectations low, and definitely try and educate them, but don't be too disappointed when they're not educatable. I have no disclosures related to this field. I don't get any money for this. So I'm going to talk to you about, you already heard a lot about alpha-1, the molecule. So I'm going to focus more on what is liver disease and how come so few people know about it. And I hear that you guys don't think that FEV1 is the be-all and end-all, but at least you have an FEV1. We do not have that for the liver. Right? There's no comparable tool. So you heard that alpha-1 can cause disease in childhood. Most of the time it's asymptomatic, but if it is symptomatic, they can have things that people associate with liver disease, which is jaundice, the liver can be big, and it's said to be one of the commonest causes of severe neonatal hepatitis. Although our colleagues at Sick Kids say they don't see it very much anymore, but it's always on their top of the list. When someone with a kid who's very sick at near birth, they always think about alpha-1. And the nice thing about it is that it's not one of the things where if the kid is very sick, you actually need a liver transplant. So I just came from a Canadian Liver Foundation gala yesterday honoring sick kids where all the stories were horrific. They had this disease, they turned yellow, and if they didn't get a transplant, they would have died. So a lot of this, though, is the opposite. They get very sick, and they tend to resolve, and then you get fooled because everything looks normal after age 6 months, and then you can get into trouble when you get older. So what does it look like in adults? So here is where it gets, this is the lack of FEV1, because there's no good tests for it. So we have normal, what we call liver function tests or liver enzymes, and they are all normal despite having alpha-1 liver disease. And cirrhosis is asymptomatic. Any one of you could have cirrhosis in the audience, feel perfectly fine. You wouldn't even know it if you didn't test for it. Okay? So it's said that 2% of those aged 20 to 50 have liver disease with cirrhosis, and ones over age 50, potentially up to 20%. But then the problem is that as you get older, other things happen, right? So alcohol comes into the mix, fatty liver, diabetes, viral hepatitis, all those things can contribute to cirrhosis as well. I will define cirrhosis for you later because it's probably not what you think. But cirrhosis puts people at risk for liver cancer, and liver cancer is how sometimes people show up in our clinics. So what are the current recommendations? I just told you that you have no symptoms, and none of our tests can tell you if you have liver disease. So it's very funny for me to read non-liver literature here and see they recommend annual monitoring. Physical examination, there's nothing to see, so I don't know what they're examining for. And ultrasound will not tell you if you have cirrhosis, not until it's way too late. Blood tests, I just told you, all the blood tests are normal. So I don't know, once again, don't know what people are looking for. So within the guidelines, there are minority opinions that say, no, this doesn't make sense because what exactly are you looking for? And to acknowledge that liver disease actually becomes more common as you get older, and maybe you should target the older people. For liver disease, old is over age 40. That's when you get more hangovers. It's actually true. Okay, so what is cirrhosis? So this is liver 101, which I'm going to put you through. Where is the liver? Who knows? Yay. Because I have people coming to see me and say, I have a pain over here, and I say, no, the liver's on the other side. And they go, oh, and they move it. Okay, so the liver's underneath your ribs on the right-hand side. Okay, and so there's a picture, pretending this is me looking at you, and my liver's on the right-hand side looking at you. Okay, so what is the main function of the liver? Who knows? Someone said filter. Oh, it's not a filter. Okay, so in medicine, we have a blood test that's called the GFR, or glomerular filtration rate. It's a measure of kidney function. So your kidney is the filter, not your liver. So what is the liver? Well, doctors learn about the liver as part of the digestive tract. So the reason why is your liver doesn't digest. It actually uses the products of digestion. So your gut, all it does is break foods down to very small molecules, carbohydrates, fats, proteins, absorbs it, goes to your liver. Your liver takes all of the raw materials, and it's your factory. It builds pretty much everything for you, including the alpha-1. Okay, so it is your factory, it is your workhorse, does everything, but you guys don't know what it does. So how does it do this? So there's a picture of the gut all sliced up, but effectively you eat food. Food goes through all your intestines, it gets digested, and then all the good stuff gets absorbed into the veins. And all the veins lead to the liver through a vein called the portal vein. Okay? So then your liver takes all the good stuff, makes everything with it. Anything that's bad, it throws away, because whenever you make stuff, you're never 100% perfect. There's always going to be some waste. And once you've made your stuff, you ship it up to the heart. Now, the heart is not shown, but it's on the very top, just above the liver, about Canadians, 5 centimeters above the liver, or 2 inches for our American friends, is the heart. Okay, so good products goes to the heart circulates it to everywhere else in your body. So that's the job of the liver. So what is cirrhosis? Okay, so most of my liver disease patients actually have hepatitis C, and it's very sad because, for example, the older Italians have a lot of hepatitis C. And if you talk to any older Italian who's 70 or 80 years old, they've all seen someone die of cirrhosis from hepatitis C, and they think of liver failure. So once you say cirrhosis to them, it's worse than saying they have cancer, because they know that the death is horrific, and they think they're going to die imminently. And I go, no, 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 no. That is not cirrhosis. So cirrhosis is not, you're going to die. It's not worse than cancer. It's not irreversible, because a lot of cirrhosis nowadays causes are reversible. A lot of people have cirrhosis and have no symptoms. You wouldn't know it until someone did a test on you. And nowadays, we're doing more and more tests, and we pick up a lot more people with cirrhosis than we ever did before. Okay? You cannot tell you have cirrhosis by doing the standard tests. So those monitoring tests that they were recommending do not work for finding cirrhosis. And an ultrasound does not tell you have cirrhosis until it's very, very late. So also not a good test. So this guy is not cirrhosis. This guy is actually liver failure, which is different. So what is cirrhosis? So cirrhosis is when you have a chronic liver disease, like alpha-1, like hepatitis, even like alcohol, such that over time, generally 10, 20, more likely 30, 40 years of damage, enough damage has happened that your liver is damaged to a point that complications can happen. And there's actually 3 complications of that can happen with cirrhosis that I want to talk to you about. So here they are. And they have to do with how they impair the liver's ability to do its work. So the very first thing that happens is that when the liver is scarred, all this blood that's supposed to go through to the liver has a hard time getting through to the liver. It will start to back up. Okay? So the pressure in the veins start to go up, and it affects different organs. So the first thing that happens is, do I have a pointer? No. Yes. Okay. So here's the spleen. Okay? The blood is trying to flow to the liver, but it's backing up here. And then high pressure in here causes your spleen to be hyperactive. We call it hypersplenism. And the first sign of cirrhosis on blood tests, which they never tell you about, is that the platelet count goes down below normal. So why don't they tell you about this? Well, it turns out that in medical school, it's the blood doctors, the hematologists, that teach doctors about low platelet count. And they think that the commonest cause of a low platelet count is something called ITP, an immune-based disorder that causes very low platelets. They're actually wrong, because in studies of adults from the US, if you don't know that they have liver disease and just check everyone for a low platelet count, the most common cause by far is actually cirrhosis. Okay, so before the spleen gets big, it's hyperactive and your platelets are low, still no symptoms. Okay? So the first real clinical complication of cirrhosis is the blood vessels that drain here, the lining of the stomach up to the esophagus, which is your food pipe. These veins happen to be on the surface of the food pipe, and because they're on the surface, they're almost like little balloons. So as the pressure goes up, the veins get bigger and bigger. They look like varicose veins. The difference between these and varicose veins is that the pressure can get so high, like any balloon, it can burst, and if it bursts, it's not painful, but your stomach will fill with blood. And if your stomach fills with blood, you'll feel nauseated and you may or may not throw up. So I tell patients, if you throw up and you see a lot of blood, guess what? You're bleeding. Go straight to the hospital. Some people hold it in, right? They don't throw up. So the blood goes through their digestive tract, gets digested, and it comes out the other end looking like road tar. Black, extremely sticky, extremely smelly, nothing subtle about this. Okay, so I tell people if either of those happens, straight to the emergency because a vein over here has ruptured and someone needs to go in there and tie it off, otherwise you could bleed to death. Okay, the chances of bleeding to death is about 1 in 6. We also tell people do not drive. I've had some people drive down from like 3 hours away because you could pass out from loss of blood. So don't drive, call an ambulance. If you have a friend, get your friend to take you to the hospital. Just be kind to your friend and take something to throw up in. Otherwise, they won't like you. Okay, so that's a pressure phenomenon, and that's the first complication of cirrhosis. So no symptoms, all of a sudden, no pain, throwing up blood. That's complication number 1. Complication number 2 is actually the stage of liver failure. And liver failure is when your liver can no longer make your proteins, your carbohydrates, and your fats. So you can expect, for example, that you might look like you're losing weight, but you're losing muscle weight. So that you can see the bones more, the face is thinner, you can actually count the ribs. And when that happens, people generally retain water, usually in their abdomen. It's almost like they're pregnant. Okay, and if you stuck a needle in, you would get tons of water coming out. So that's called ascites, and that is the stage of liver failure. Okay, so pressure, bleeding, number 1, liver failure, water, number 2, and the third complication that can happen at any time during cirrhosis is liver cancer. Okay, and liver cancer is yet another one of those things that has no symptoms until it becomes very big and it's too late. So this is my cartoon to explain what this is. So the older people will know Alfred E. Newman from Mad Magazine, and his motto is, "What me worry." And that's very true of liver disease. So if you imagine that this is how much liver you have left, and you've lost, say, 40% of your liver, you wouldn't know. You'd feel perfectly fine. Okay? If you lost 60% of your liver, your platelets might be low, and if you didn't get checked, you wouldn't know. So people frequently ask me, okay, I have liver failure, how much of my liver have I lost? And they think maybe I'll say 30%, 50%. But if they actually have true liver failure, I tell them you've lost 90%. Okay? Because when we do liver transplantation, you can donate, we have donors that donate part of their liver. When they say donate part of the liver, it means you've lost 2/3 of your liver, and you're still fine. You don't go into liver failure until you've lost like 80 or 90% of your liver. Okay, so these are the stages of cirrhosis. We actually know they go from stage to stage. The first stage means you have no symptoms whatsoever. Second stage means you've got those veins that have never bled. Third stage means you've ever had a bleed. And fourth stage is the stage of liver failure, which is ascites. Okay, and with each phase, the risk of death, risk of surviving the next year goes lower and lower. And it's not until you get ascites that we actually start thinking about transplant, because the survival probabilities above here are all better than transplant. So transplant when you have ascites and not before, so stage 4. Okay, so I just told you none of our tests are good, none of the guidelines for monitoring are any good. So is there anything we can do? I told you about platelet count under 150, be suspicious. Statistically for adults, if your platelet count is 150 or lower, there's a 2/3 chance you have cirrhosis. If you're known to have liver disease and your platelet count is low, then it's a 90% chance you have cirrhosis. Okay? So ultrasound is not good until it's too late. Cirrhosis that's early looks like fatty liver. So I also tell people if you're skinny and they tell you have fatty liver, be very, very cautious, because that might not be fat, that might be cirrhosis. So why are we in such trouble? How come we can't tell people have cirrhosis? It's because of this. Nobody likes this, right? It's a liver biopsy. It kind of does look like this. Is it Believe it or not, that's not too bloody. The bleeding does happen. You stick that needle. The needle is about 10 centimeters into the liver, and it's a pretty big needle. And that's why we tell people to look the other way when we do this. I do this biopsy procedure pretty often, actually. So I chat them up, I distract them, give them some medications to make them a little bit sleepy, wash the skin, freeze the skin, do the biopsy, and I'm done. Okay? But it is a long needle. It's generally very safe. Okay, I've never had a serious complication ever in my 30 years of doing this. But statistically, one severe complication per 10 years of doing this, if you do any biopsies. Severe complication being a major bleed requiring hospitalization. Most of the time, though, 1 out of 5 times, you have a trivial amount of bleeding. So small you can't see it, even if you do a CT or an MRI. But a small amount of bleeding there is effectively a bruise. And if you push out a bruise, it's going to hurt. So by its location near the lungs, if you take a deep breath, it might hurt. So I tell people 4 out of 5 times, you're not going to feel anything. 1 out of 5 times, you have a bruise, and a bruise can last up to a week. So it's not pleasant. And the thing about a biopsy is that it'll give you a one-time read of what the liver is doing, but then what about the future? Can you do the biopsy over and over and over again? So up till the 2000s, we used to do exactly that. You have liver disease, things might be progressing. Today, the biopsy is not bad. Let's do another one in 5 years, maybe do another one in 5 years after that. So that's how we used to practice liver disease. And that's the reason why we know so little about liver disease, because a lot of people don't want to do this. This is what you get. And if you know what you're looking at, it's great because you can actually see stuff. This is a normal liver. All these are liver cells. The blood flows from left to right. This is hepatitis. So all these are your immune cells fighting something like hepatitis B, hepatitis C. And these white holes are fat. And this is cirrhosis, broad bands of scar surrounding the liver. None of this is alpha-1. Okay, this is the most common reasons why we do liver biopsies. Now, along the way, over time, something amazing came up, and that was hepatitis C, because hepatitis C is pretty common in our society. So a lot of money got thrown at hepatitis C. So they biopsied thousands of people with hepatitis C to prove actually hepatitis C was a disease, that it actually caused more scarring over time. And they concluded, yes, hepatitis C causes disease. Believe it or not, in the 1990s, no one was sure. But they also concluded that patients hated biopsies, and that biopsies were more trouble than they were worth, because a third of the time, if you weren't careful, you didn't get enough liver, and the pathologist said, too small, do it again. Yeah, exactly. So this guy by the name of Thierry Poignard, very shrewd Frenchman from Paris, what he said was, people hate biopsies. Why don't we see if we can do blood tests and find a surrogate marker? So of the same patients, he biopsied almost 2,000 people. He did every conceivable blood test. And he said, you know what? If I do 5 blood tests, and these are the 5 blood tests, GGT, bilirubin, alpha-2 macroglobulin, haptoglobin, apolipoprotein A1, big words. And if you know the age and gender of the person, you can put it into a secret formula. So he said, do your blood test from your doctor, come to my website, give me your Visa or MasterCard. I charge you 50 euros, and I'll tell you how much scarring there was. Okay? The Europeans just ate this up. They stopped doing biopsies. The North Americans said, forget that. We're not going to pay this guy 50 euros. They attacked him. They said, your thing can't be accurate. You're wrong. So he was forced to do study after study after study showing that his formula was correct. And he was correct. Okay? But in doing all these studies, his resident or his student published a paper, and he put the methods in the methods section. He put the formula, the secret formula in. It's like KFC. So it's published, and it's now in Wikipedia, and we don't pay him the 50 euros. So we do that, okay? Now, the problem is that, you do a blood test. It takes time to get back. So down the street from him, also in Paris, were a bunch of liver specialists who liked wine and cheese. So when they were doing a cheese tour, they realized that the cheese people had quality control. And the way they did this is they had this big block of cheese, and they did a biopsy of the cheese, and they tasted it. And they said, hey, the cheese, it's this, it's that. But they could never tell if the texture was good enough because they didn't know how hard it was. It was a small biopsy. So what the cheese people made is they made a new gadget, which became FibroScan. So if you knock on the cheese, you can tell how hard it is, right? If you knock, depending on where you knock, it's different, right? And so the liver specialist said, wait a minute, the liver is just like cheese. So they created this machine. See, they're all smiling. And he's got this very expensive probe that costs $40,000. And all the probe does is it knocks, and then it sort of listens to the liver by telling how fast a sound wave goes through the liver. And it gives you this picture that looks like this. So this is the distance into the liver, and this is the time. So the harder the liver is, the faster this pressure wave takes to go through the liver. So you now have a way, without doing a biopsy, of telling how hard the liver is, which is another way of saying how much scarring there is, or are you on your way to cirrhosis or not. So this is now the best test we have for telling about the liver without doing a biopsy from cheesemakers, okay? So what can we do about alpha-1 in the liver? So you've heard what alpha-1 is. It is made in the liver. So can we have any hope? And the answer comes from all the other diseases. So until about 1998, we always thought that when you had liver disease, you hit cirrhosis, you're eventually going to die. It's a one-way street. But since the 1998s, we've had a lot of diseases that we can now treat. So hepatitis B became treatable in 1998. Hepatitis C first became treatable in 2002 and is now really curable in 2014. And all these other diseases, when you treat them, the cirrhosis got better. Liver failure went away. So it's not a one-way street, it's a two-way street. So the lesson became, if you can find whatever is causing damage to your liver, then if you treat it, your cirrhosis and your liver failure can actually get better. So we still have some challenges. So alcohol, it's not so easy to get people to stop drinking. And fatty liver is predominantly caused by diabetes, and it's very hard to cure diabetes. We can control it, but not good enough for the liver. What about alpha-1? So that's the big question. So I'm going to show you two biopsies. So this is hepatitis B, and this is alpha-1. And you can see hepatitis, this is your immune cells, your lymphocytes. They're fighting the virus, trying to keep it under control. But if I give you now a pill that suppresses hepatitis B, all these lymphocytes will go away, and this liver biopsy will now look normal. Okay, the damage will go away. The problem with alpha-1 is that there are no lymphocytes. Your immune system's not fighting anything. It's just that the alpha-1's sitting in these liver cells in these big magenta purple globules. And it's there that it's doing its damage without causing any inflammation, immune attack. And the reason why this is the reason why your blood tests are normal. It's because there's no inflammation. So inflammation is what we call hepatitis, and all the blood tests go up. Here, they just sit there. Your blood tests are normal, and if you just look at the blood tests, you would never know you had alpha-1. Okay, so complex picture. They've already told you about all this stuff, so I'm going to go through it pretty quickly. You know that the liver is what actually makes the alpha-1, and then it goes to the lung to protect, okay? And the reason why we have alpha-1 disease at all is because the protein, there's a mutation, the protein is misfolded, and it can't get out of the liver. So because you got all this background, I'm going to show you this slide. I usually skip the next slide, but since they did all the background, I'm going to be unkind to you and explain exactly what's going on. Okay, so a protein that's made is just one big long string, but the big long string will not work. You have to fold the protein into the correct shape. And the reason why it folds is because the proteins are all charged, they're all like little magnets. But each magnet has to find the right spot to come together. And when you have the alpha-1 mutation, what happens is that the magnets no longer recognize each other, and you have, this thing looping out. Okay, so it's not folding in the way it's supposed to be. And the problem with this folding out thing is that it's like a little handle, and it now attracts another alpha-1 protein. Okay, you can see these things linking together, and that's what alpha-1 ZZ looks like. It's a bead of strings, and this big long thing has a tough time getting out of the liver. Instead of one little protein that's easy to get out, you have these big long things, like almost like a stack of frisbees that's stuck inside your alpha-1. Okay, so how come most people with lung disease don't have liver disease? So here's where I say it's because the liver is smarter than that. Most people know what to do with retained alpha-1 in the liver. Because you don't want it stacking in there and damaging your liver, you have defenses. We think we know what's going on. We hope we know what's going on. At least there are some few theories. And these are two of the predominant theories that are going on right now. I'm going to tell you their names. You're going to forget about it really quickly. But there's something, have you heard of the word ubiquitous, which means it's everywhere? Well, it turns out there's this protein called ubiquitin that ubiquitin is another protein. It's like a tag. It's like a post-it sticky. So if you put ubiquitin on a protein, you say, this is garbage, get rid of it, your liver will get rid of it. Okay, it's called ubiquitination. So that's one potential mechanism. And the other potential mechanism is actually more elegant. It turns out that when you're starving, you have to keep on going to find food. This is from our ancestors. So one of the ways of getting energy is something called autophagy. Auto means self, phagy means eat. So you're eating yourself. But it also turns out to be one of the ways we defend ourselves from things that are accumulating. So what you do is you throw a membrane around what you don't like, that you want to get rid of. You can actually digest it. So those are the two theories on how we get rid of alpha-1. And this one is one of the things that people are working on because they think that if they can increase autophagy in your liver, you can actually get rid of the retained alpha-1 in your liver. Okay, so it's theory anyway. So we have some mice experiment where it's being shown that if you induce alpha-1 with this autophagy mechanism with a drug called carbamazepine. So why am I telling you about carbamazepine? It's because this drug is already on the market. It's an anti-seizure medication. And people are hoping that this medication can get rid of retained alpha-1 in the liver. At least it works in mice. The problem is that you need very high doses, and we don't know if we can get high enough doses into people for this to work. Another way is now more space-aged. When you have a gene, which is DNA, the way it comes to protein is you make a little copy of it called RNA, and the RNA is what makes proteins. But if you put another RNA that can attack this RNA, so called an siRNA, it prevents this RNA from making any protein. So there's a couple of companies that are making this technology for people with alpha-1 liver disease. They're hoping to shut off the production in the liver. So will it help your lung disease? No, because you have even less circulating alpha-1 in your lungs. But if your liver is jam-packed full of this protein, this can probably turn it off. Okay, and this is mice experiments showing, with alpha-1, an alpha-1 mouse, if you just give it nothing but saline, over time, this is at 5 weeks and at 13 weeks, there's lots of alpha-1 in the liver. But if you take the same mouse and you give it this alpha-1 siRNA, all the alpha-1 disappears from the liver. So potentially, right now, there's no treatment for alpha-1 liver disease, but in the future, there will be techniques to get rid of alpha-1 from the liver. Okay. So where are we with alpha-1 right now? And the answer is because in the past we've depended on liver biopsies, we are not very far at all. So one of the questions is, when should I check for alpha-1 liver disease? Because it takes a lifetime to accumulate protein. If I do a biopsy at age 20 and there's nothing, does that mean I'm safe for life? We don't know. Because what if you biopsy at age 40, there might be some alpha-1. What makes alpha-1 accumulate as versus get degradation? So I showed you two theories. One is autophagy, the other one, by siRNA, we can get rid of alpha-1. So how do we approach this? What are we doing currently? So I work in Toronto General. I'm seeing a lot of people with identified alpha-1, mostly because of lung disease, but some people are identified because of liver disease. So what I say to them is we do some assessments and we ask the question, what is your platelet count? Is it over 150 or is it under 150? Under 150, we start to worry about you. We do some tests to estimate how much scarring there is in your liver. So currently we're doing fibrotest and fibroscan in everyone. Is it well validated in alpha-1? No, it's not. There are people starting to look at it right now, but we're using the hepatitis C numbers to say, do I think your liver is normal or do I think there is scarring? And then we offer people liver biopsies. So right now, the liver biopsy is just to know, am I accumulating now, yes or no? But the question is, if I'm 20 years old and I do a biopsy now, what about 20 years from now? In the future, when we have these other therapies coming, I think it will be important to know if you have alpha-1 liver disease or not, because potentially we can treat the liver disease. If we find people who are too late, they already have cirrhosis, then there are things that we can do. We can steal a page from what you guys are doing, which is instead of lung care or alpha care, we can talk about liver care. Because for cirrhosis, we know that the main risk for life is liver cancer. And what we tell people to do is do an ultrasound every 6 months. Because if you find a cancer that's small, it's curable. But if a cancer is beyond 3 or 4 centimeters, it's no longer easily curable. So ultrasound every 6 months. And if there's liver failure, then liver transplant is an out that can still prolong survival. So all hope is not lost, even if you have liver failure. Okay, and that's it.